Dear friends and all the fellows and residents who have taken out time to join with all of us in a new journey that we are going to start today. And I welcome you all on behalf of the Cardiology Society of India Delhi branch to this beautiful program of Clinical Pearls, the PG track program designed specifically and especially for you, especially for you. So And it is pertinent for us to note that while so many webinars are happening throughout the day, all over the country and in fact all over the world, I thought that the CSI should design some specific programs for all of you. And the whole team joined together and is taking a great initiative to start special programs for you from today. And we have the privilege of having Professor Anita Saxena and Dr. Saurabh Gupta from All India Institute of Medical Sciences, who will be triggering this journey for all of us today. And we are also very delighted to have Professor Girish MP and Professor Sumod Kurian from GB Pant Hospital, Delhi, who will be moderating this session. This is the first session, and if you have any questions, you are free to type them, and we'll put all the questions at the end of both the lectures. The moderators will be asking. And along with this, if you have further questions and clarifications, you can write to us on the email which was being projected and again will be projected. That is pgtrackcsidb@gmail.com. So over to Professor Sumod and Dr. Girish for starting the session. Dr. Girish and Dr. Sumod.
Yeah. Good evening, everyone. And today we have the privilege of having two great teachers in the form of Professor Anita Saxena and Dr. Saurabh Gupta, both from All India Institute of Medical Sciences, who are here to um, give their lecture upon update on cyanotic congenital heart disease. I now invite Dr. Saurabh Gupta to start his talk on approach to a cyanotic congenital heart disease. Over to Dr. Saurabh.
Yeah. Thank you, Dr. Girish. Thank you, Dr. Mohit, for having me here on the webinar. And without taking much time, I'll straight away share my screen. And then by the time it is being projected, I'll introduce myself. So as was briefly mentioned by Dr. Girish, I'm Dr. Saurav from AIMS. I work as pediatric cardiologist over here. And so I'll immediately go to the slide set and we'll start with that. So this is the hemodynamic classification of congenital heart diseases. And as you would see, that there are three major presentations with which the patient with congenital heart disease would present. One would be hypotension with shock, or another can be cyanosis, or the third one is heart failure. And we are today talking about this group, which is in the red box, cyanosis. Now, as you could see here, that there are three different groups in this category also, and I'll further elaborate upon that. Before I go there, for the beginners or not so beginners, I'll just remind that cyanosis can be acrocyanosis when it is limited to the extremities. It can also be central cyanosis when it is all over the body, and acrocyanosis, while it does not indicate any congenital heart disease, it is just a local issue. The central cyanosis is almost always related with either circulatory or respiratory abnormality. And differential cyanosis or reverse differential cyanosis is a form of central cyanosis, which also indicate that there is PDA which is involved in the circulation in some or the other way. Now, causes of persistent central cyanosis are, you can go by the approach of A, looking at the airway. It can be breathing related issues when the lung parenchymal issues are there. Third, C is the circulation, which is our topic of discussion today. D is the defective hemoglobin, where methemoglobinemia, sulfamoglobinemia, hemoglobin M, and other hemoglobinopathies can result in cyanosis even if the PO2s are normal. And there are other miscellaneous causes which are more pertinent in the children or neonates. Now, what are the determinants of detection of cyanosis? This is very important because I wish you all of you to understand that what are the problems when we take cyanosis as the marker of congenital heart disease. And I'll come to that later. So one is the skin color. As we all know, if the skin color of the baby is dark or the patient is dark, it's difficult to appreciate cyanosis. Hemoglobin level and type. And then this diagram shows that what is the relationship if the patient is a child, newborn, or an adult. And depending upon this, the oxygen dissociation curve is different. And because of this, our oxygen saturation for the same degree of PO2s are different. Experience of the examiner is well known. While an experienced person may pick cyanosis even at a saturation of, say, 90%, the beginner may not pick even when the saturation is 70%. And the effect of acidosis and alkalosis is known to all of you. Now, this is the effect of hemoglobin level. As you would see here, as the total amount of hemoglobin goes up, our tendency or our ability to detect cyanosis improves. If we consider cyanosis is detected at reduced hemoglobin of 3 gram percent, then a child who has a 20 gram percent hemoglobin will be able to easily diagnose cyanosis at 85%. But as I mentioned earlier, it also depends upon the examiner who is examining for the cyanosis. So there are a lot of factors which determine how we are picking cyanosis. So if we take cyanosis as a screening tool for congenital heart disease, it has lower sensitivity because it depends upon a lot of factors. It has low negative predictive value because not all the time you have cyanosis, even when the patient is actually having a lesion which causes right to left shunt. It has high positive predictive value. It has high specificity, but then if you use these two criteria, you might miss some of the CHDs. So cyanosis should not be used as a screening tool. It may be used to confirm that yes, if cyanosis is there, it is very likely that the patient has congenital heart disease or some other serious form of respiratory disease. So all children should have pulse oximetry, and we should not just rely on visibility of cyanosis as a marker of cyanotic heart disease. And arterial desaturation is not same as cyanosis for the same reason which I just explained. Now, coming back to the same chart which I shared with you earlier, and as you would see here, I have replaced cyanosis with arterial desaturation because quite a few lesions among these causes desaturation, which is to the tune of 92%, 88%, 90%, which may be easily missed in the clinics. And therefore, I prefer using the term congenital heart disease with arterial desaturation rather than using the term cyanotic congenital heart disease, and the reasons I have just elaborated upon. Now, looking at this group of diseases carefully, it can be divided into decreased pulmonary blood flow with low pulmonary artery pressure, which is like our typical tetralogy physiology, or others like critical PS with atrial septal defect, where there is obstruction to the outflow, pulmonary outflow, and there is a shunt which is allowing blood to go from the right side of the heart to the left side, either through VSD, as in TUF physiology, or through ASD, as in this case. The other bigger group is increased pulmonary blood flow with high pulmonary artery pressures, where there is actually pulmonary blood flow which is high. These two have transposition physiology and admixture physiology, and we'll come to it slightly later. And there can be another group where there is no PS, there is normal pulmonary artery pressure, but still the patient has cyanosis, like in Epstein's anomaly or anomalous systemic venous connection. Now, just to make you understand how cyanosis develops in a patient of congenital heart disease, this is the normal heart. The blood comes from the systemic veins, goes to the lungs, and this constitutes QP, the pulmonary blood flow. And since there is no right to left shunt over here, this QP is all which is used for oxygenation. So it is also the effective pulmonary blood flow. So the systemic venous return is equivalent to pulmonary blood flow, which is also equivalent to effective pulmonary blood flow. On the left side, similarly, the pulmonary venous return is going to the left side of the heart and is going to the body. So the pulmonary venous return is equal to the systemic blood flow and is also equal to the effective systemic blood flow, which is accounting for oxygenation of the tissues where it is required. Now compare it with this tetralogy physiology, where the blood is shunted away at the level of VSD and therefore this some amount of the systemic venous blood is getting stolen into the arterial system, and therefore the QP is reduced. So the QP is less than the total systemic venous return. And how much less? It will depend upon how much is the right to left shunt happening. So the QP is equal to QEP, but it is less than the systemic venous return. On the other side, QS, the cardiac output, is equal to effective systemic blood flow plus right to left shunt. So the QP is less than QS. So in real terms, absolutely QP may not be reduced, but when you relate it with the QS, there is reduction in QP by QS. So this physiology will have QP by QS less than 1, and like normal, PA saturation will be less than the FA saturation. Now this is admixture physiology. Admixture, as the name suggests, the blood is mixing in one of the chambers. It can be at the level of systemic veins when it is TAPVC. It can be level of the atrium when it can be common atrium, or ventricle when it is single ventricle, or at the level of great arteries when we are talking about truncus arteriosus. Now, if we look at this physiology, since the whole of the blood has mixed in one of the chambers, the blood reaching into the lungs is almost equally saturated as it would reach to the aorta. So the saturation in the PA is equal to the saturation in the femoral artery. Now, what is happening here is there is some amount of blood which is going from the systemic venous side to the systemic arterial side, and there is some amount of blood which is coming from pulmonary venous side and getting into the right ventricular side. So what is happening is the lungs are receiving blood from the systemic veins plus the blood which is coming from the pulmonary veins minus the blood which is going away from the systemic venous side to the left side as right to left shunt. On the other side, this is the calculation which will happen. So what happens is the QP is not equal to QS, and the QP depends upon the pulmonary stenosis or the resistance which is happening at the level of lung vasculature. It also depends upon the streaming, and therefore PA saturation is almost equal to FA, but there is some minor variation which is acceptable even in this physiology. As we all know, the effective pulmonary blood flow always remains equal to effective systemic blood flow, and that will remain in this case as well. Now, coming to the most drastic of these congenital heart diseases, which has arterial desaturation, which is TGA physiology, where there is anatomical barrier because of the reversal of great arteries, and the blood which was originally destined to reach the lungs is now reaching the body. So there is 100% physiological right to left shunt, and whatever is coming from the pulmonary venous side, which is the anatomically left to right shunt, is actually the effective systemic blood flow. On the other hand, whole of the blood which is coming from the pulmonary veins is getting into the lungs without contributing to the systemic oxygenation, and only the amount of blood which is coming from the right side or the systemic venous side, which is anatomically right to left shunt, is contributing to the pulmonary oxygenation or lung oxygenation. So this is QEP and this is QES. And therefore, despite torrential increase in the pulmonary blood flow, the effective pulmonary blood flow is much less. And therefore, these patients have PA saturation much more than FA saturation, and they have cyanosis disproportionate to the pulmonary blood flow. Now, when we evaluate a patient for arterial desaturation, we must differentiate for respiratory causes, and mostly it is mostly possible, but not always easy. So if we do initial assessment, we should base our decision on history, clinical examination, ECG, and chest X-ray. And I would say that this is the composite which leads us to hemodynamic classification, which I just discussed with you some time back in most of the scenarios. Making an accurate diagnosis is seldom essential for initial management, and therefore it is not always necessary to make a correct diagnosis at the bedside. Even if we are able to achieve the hemodynamic classification, that should be good enough. Now, history should start from antenatal, perinatal history, family history, feeding history, growth and nutrition, because this tells us which group of congenital heart disease with arterial desaturation we are talking about. Again, recurrent LRTI has the same meaning. Whether the parents have noticed cyanosis, because once the parents and the relatives starts picking up cyanosis, it means that the patient has significant desaturation, which is visible to even them, to the inexperienced examiners. Now, what are the peculiar characteristics of cardiovascular related desaturation? Once we know this, it is easy to differentiate it from respiratory causes. This desaturation usually early onset, and there is persistent prominent desaturation. It results from reduced effective pulmonary blood flow, which I just mentioned. Desaturation worsens with age in most lesions, except in some like I've seen where there can be bimodal presentation. Desaturation is usually out of proportion to respiratory distress which the child may have, does not normalize with oxygen, although minor improvement can happen, and that should not be confusing the people who are examining the child. Hyperoxia test is no longer performed, although the principles can be used to make our understanding better. I will not go into detail of that. Now, based on when the patient is presenting, these are the different conditions which are present on in week 1, first month, and late. And this just depends upon what is the effect of this congenital heart disease on the circulation during the fetal life and in the neonatal life. And I'm not going to be in the details of that. Now, what do we mean by comprehensive clinical assessment? As I said, we must focus on airway, breathing, and circulation, pulse, capillary refill, saturation, BP in both pre and post ductal location. Evidence of heart failure would indicate that the patient is actually having increased pulmonary blood flow, even if the patient has cyanosis. So what I have emphasized till now is cyanosis is not always synonymous with reduced pulmonary blood flow. It is synonymous with reduced effective pulmonary blood flow, but not total pulmonary blood flow. And we must differentiate between these two conditions. Dysmorphism and other anomalies will help us in pinpointing towards the congenital heart disease. In cardiovascular examination, most of the findings which are in the cardiac evaluation, cardiac examination per se, will tell us whether we are dealing with reduced pulmonary blood flow, increased pulmonary blood flow, and sometimes it will give us insights into the underlying etiology. Pulse, it's very important, and we'll know we'll come to that later on. Now, once we see a patient with arterial desaturation, comprehensive clinical evaluation is mandatory. Cardiac auscultation may not be as useful. This must be kept in mind, especially if it is a neonate or a young infant. Murmur is neither sensitive nor specific to rule out congenital heart disease. Serious lesions like TG and TAPVC may not have any murmur. Mild lesions like pink cough may have loud murmur, and even then, their underlying disease is something which requires surgical intervention in early childhood. Now, some of the clinical signs, I'm sure ma'am would be taking up this in a little more detail. So I have just briefed it out. In the presence of cyanosis, the patient has LV type of apex. There are only few conditions like tricuspid atresia, single ventricle of LV morphology, or DORV with restrictive VSD. While if the patient has pulsation in the second left intercostal space, it indicates that we may be dealing with congenital corrective transposition of great arteries. Pansystolic murmur or AV valve regurgitation in the setting of cyanosis or arterial desaturation indicate AVSD or CCTGA. Early diastolic murmur would indicate truncus arteriosus, and the beauty about this sign is that this can be heard even in a neonatal period, and it gives a clue to the definitive diagnosis even at that age. Seesaw murmur would indicate TOF with absent pulmonary valve, and if the patient has complete heart block, which can be even thought of at the time of examination, it indicates that we are dealing with either a congenital connected transposition of great arteries, AVSD, or single ventricle. But the problem, particularly in neonates and young children, is that many lesions, including critical CHDs, which would require intervention or surgical intervention during infancy, are asymptomatic. And as we all know, misdiagnosis or delayed diagnosis cause considerable mortality and morbidity in these children. So we have to think of something which can help reduce that gap of disease versus detection. Now, in that, universal screening of echo is not feasible, not cost effective. So we must combine it with saturation, clinical examination, ECG and X-ray. And I'll tell about X-ray here before going to the further detail. So if we use X-ray for congenital heart disease, if the patient has cardiomegaly, we are dealing with either increased pulmonary blood flow, or in some instances, even conditions like Epstein's anomaly or pulmonary stenosis with ASD, which has large right atrium would lead to cardiomegaly. But what is important to note here is that these changes, these radiological changes in X-ray are age dependent, and we should not be expecting them in neonates or in early few months of life, and they take some time to develop. So we should, whenever we are seeing a child, if the child is young, we should not be looking for this typical figure of eight sign, egg on and side appearance. Rather than that, we have to look at the total cardiac size, the pulmonary flow, and other things to come to our diagnosis. And we should not just rely on some specific prototype X-ray findings. Now, when the condition is not having cardiomegaly, then we are dealing with reduced pulmonary blood flow, like TOF physiology, or there can be normal pulmonary blood flow, but still the patient has cyanosis. It may be because of anomalous systemic venous connection. Sometimes it may be related to obstructed TAPVC, and then the patient has pulmonary edema type of picture, and it would be easily identified. Now, this is how you evaluate a patient based on X-ray, and X-ray gives us a lot of information about heart position, size, abdominal situs, heart size, pulmonary blood flow, and based on that, we can differentiate whether the patient is in the group of pulmonary plethora versus pulmonary oligemia, and thereafter we can further classify them into TOF physiology and other categories. Now, it is again important to initially differentiate whether you are dealing with a patient of reduced pulmonary blood flow or increased pulmonary blood flow. And this is the summary of how you can differentiate. And as you would see, all the symptoms and the sign of heart failure, chronic heart failure, which you expect otherwise in a patient with VSD, moderate or large, would be seen in all these patients with cyanosis or desaturation, the increased pulmonary blood flow also. So if the patient has cyanosis with all these signs, you should be thinking of conditions which are having increased pulmonary blood flow. If the signs are not there, then you should be thinking of conditions with reduced pulmonary blood flow, and I have elaborated upon chest X-ray already. Now ECG. Now we must see the age of the patient before we can comment upon ECG. It's very age sensitive parameter, and an abnormal ECG in terms of age related abnormality in the waves, axis and voltages would indicate that the patient is having CHD, and some of the conditions can be thought about if we have some specific ECG findings. Like if there is RVH with right axis deviation, then most of the conditions of pathology physiology will fit here. But if the patient has LV dominance with left axis deviation, we are either looking at tricuspid atresia, or we are looking at pulmonary atresia with hyperplastic right hearts and hyperplastic right ventricle. Unfortunately, even all this clinical examination, X-ray and ECG is not enough, and we need to do something more. And this is what from European Journal of Pediatrics, if we do depend upon prenatal ultrasound and clinical examination, then we are left with this much diagnostic gap, and which is not good. So we must add pulse oximetry in young children or in our setup whenever the child is presenting, so that we are not missing out on these patients who are having arterial desaturation, which may not be visible. Now, this is the principle. As we all know, pulse oximetry is more sensitive than cyanosis, and I have elaborated upon why it is so. It detects alteration in the blood flow pattern as well. And if we do pre-ductal versus post-ductal, we also come to know about differential and the reverse differential oxygen desaturation. And it tells us that the PDA is also involved in the circuit. Now, this is how we do pulse oximetry screening in the neonates. Some of you who must be from the pediatrics background or who would be seeing some of these kids in their practice, it would be useful that if the patient is having significant desaturation less than 90%, then it suggests highly suggestive of congenital heart disease with arterial desaturation. While in other cases, if it is intermediate, you should be repeating and then only labeling them having less likelihood of congenital heart disease with arterial desaturation. Now, pulse oximetry screening is targeted mainly to detect these lesions with arterial desaturation. Now, so to summarize, till now, if patient comes with cyanosis, you should think whether the patient has mild cyanosis. Then these are the lesions which are mostly there. If the patient has deep cyanosis, then these are the lesions which should be thought about. and it will all change depending upon at what age you are seeing the patient. Younger the patient, higher the likelihood of having these conditions with increased pulmonary blood flow. Older is the patient, higher the likelihoods of having conditions with reduced pulmonary blood flow. Now, this is just to make you understand that not all congenital heart diseases can be correctable, and in some, correction is possible where it may require neonatal intervention. In others, it may require multi-stage palliation, and it is just to sensitize people who may be here and who may see some of these kids. Now, coming to the prototype of TOF physiology, I thought that no discussion on cyanotic heart disease can be complete without discussing on this. So TOF physiology includes TOF variants and other lesions with pulmonary obstruction and a shunt lesion. So this is what typical tetralogy of fallow is. Severe subpulmonary obstruction with intracardiac shunt, typically the VSD, but sometimes we see a similar finding in ASD, although physiologically and on physical examination, they should be considered separate from each other. Now, the cyanosis is sometimes late onset in these conditions because of progressive RVOT obstruction, which is because of muscle hypertrophy and fibrosis, and also because of increased demand of the growing child. Physical examination, as we are aware, it leads to central cyanosis with widely variable, but which the cyanosis can be widely variable depending upon the severity of RVOT obstruction. Near normal saturation may be there in pink tetralogy, and they may be deeply cyanosed. It is determined by the severity of RVOT obstruction, and this RVOT obstruction is the one which determines the hemodynamic severity of tetralogy of Fallot. This hemodynamic severity is mostly has a good correlation with anatomic severity in tetralogy of Fallot, although sometimes there can be variation, but for all practical purposes, it is the same. There is no heart failure, there is no growth restriction, and heart failure is only if there is RV or LV dysfunction. Associated LVOT obstruction of the patient has anemia, hypertension, aortic regurgitation, infective endocarditis, or VSD restriction. On examination, there is quiet precordium, no parasternal heave, because the RVSP is equal to LVSP, and RV has a decompressing chamber through LV into the aorta. Parasternal heave can be present if the VSD is restrictive. JVP is usually normal, except if the VSD is restrictive, or in adults when the A wave can be prominent, and I think ma'am will take this in a little more detail. Usually they have no cardiomegaly because the net amount of blood handled by the heart is less than normal, and the apex is formed by RV. On examination, S2 is single, which is usually a single A2 with soft inaudible P2, which is because there is prolonged RV hangout interval. P2 is soft also because the pulmonary valve is quite abnormal. In some cases, P2 may be heard, usually in pink TOF, but it will have wide split. It will happen if the pulmonary blood flow is good and pulmonary mobility, the mobility of the pulmonary valve is good. And P2 is absent in cases with TOF with pulmonary atresia. Now we have ejection systolic murmur, and the intensity of this murmur would depend upon the amount of blood flowing across RVOT. Higher the pulmonary blood flow, lesser is the cyanosis and louder is the murmur. And it also depends upon the viscosity of the murmur. And therefore, if the patient has anemia, the murmur would be louder for the same degree of obstruction at RVOT. If the patient has a hyperviscosity, the same murmur will become less prominent. So depending upon where is the major obstruction, the location of the murmur may vary from upper left external border to somewhere in the third left external border. ECG is, we know that there is early transition RVH with the deep S waves in V5, V6 and lead 1. Chest X-ray is typical of boot-shaped, and I'm not going to the details of that. Now, we must differentiate between TOF variants versus TOF physiology, like lesions. So these are the TOF variants, which has baseline underlying anatomy, which is like tetralogy, but there is variation in the pulmonary artery or some additional aspect of it. So one is tetralogy of Fallot with pulmonary atresia, which accounts for almost 20% of TOF. It causes earlier onset of cyanosis, and the cyanosis depends upon the adequacy of PD or MAPCA. There is no ejection systolic murmur for the obvious reasons. They may have continuous murmur of PD or MAPCA, and X-ray may show reticular patterns depending upon whether the collaterals are supplying or whether it is the PDA which is supplying the pulmonary arteries. Ascending aorta is more dilated than tetralogy of Fallot. As you would see here, the ascending aorta is more prominent. Now, the second variant is TOF with absent pulmonary valve, which is seen in almost 2.5% cases of tetralogy. And they present earlier in life with heart failure and mild cyanosis. They may have associated lung abnormalities, which accounts for respiratory distress. And they typically have seesaw murmur or two on fro murmur. Cardiomegaly with prominent pulmonary artery segment is typical of TOF with absent pulmonary valve. Now, these are some of the uncommon variants, which would mean that less than 1% of the tetralogy cases would have that. One is tetralogy of Fallot with absent pulmonary artery, one-sided absence of pulmonary artery. TOF with branch pulmonary artery coming from ascending aorta. TOF with restrictive VSD. Now, while these two cannot be differentiated clinically, TOF with restrictive VSD is typical in the sense that they may have lesser cyanosis because the RV pressure is suprasystemic and it may surmount the RVOT obstruction to some extent, increasing the flow. But at the same time, RV is at the risk of RV dysfunction, so they are prone for heart failure, and JVP may show prominent A wave compared to the V wave. Parasternal heave may be present in these cases. And this is one example of TOF with LPA from aorta, where there is right side which is having low vascularity, and this is what we call pleonemia. Now, coming to the TOF-like congenital heart diseases, first of all, why they are different? They are different because for the same degree of pulmonary obstruction and pulmonary blood flow, QEP, the effective pulmonary blood flow, is much lesser than TOF. And I'll bring to this slide again. So if in case of TGA physiology, as you said, as we just saw, the pulmonary blood flow is much higher, but then the effective pulmonary blood flow is much lower. Now, if the patient develops PS in this setting, then what happens? Even this flow, which is coming from the right side, which is actually the effective pulmonary blood flow, is further reduced, and the discrepancy between pulmonary blood flow and the effective pulmonary blood flow further increases, and therefore they have much severe cyanosis for the same degree of QP. So they have early onset of cyanosis. The QP is much more than QEP. Flow across RVOT is relatively more compared to TOF, and therefore murmur across RVOT is louder than tetralogy of Fallot, and cyanosis for the obvious reasons would be more than TOF for the same degree of pulmonary blood flow. So few specific lesions, I think DORV, we all know if it is subaortic VSD, then it will behave like TOF. If it is subpulmonic VSD, it will behave like TGA. If it is non-notable, then it can behave like admixture, and then it represents all the variation in cyanotic heart disease which we can know of. In the TGA, as I just said, that they'll have relatively deeper cyanosis, louder murmur, biventricular hypertrophy with right axis deviation would be seen on ECG, and the X-ray would have typically relatively narrower pedicle. Now, CCTGA VSDPS is a typical condition with double discordance, and I think because it is more seen in adulthood, ma'am will be taking up in a little more detail. I'll just briefly say that CHB is seen in as the patient grows older. CHB is seen in quite a proportion. So looking at the pulse and the rhythm gives us a fair idea whether we may be dealing with congenital a corrected transposition of great artery. So we must look on that. Palpable A2 gives a good suggestion, and AV valve regurgitation, if it is present, it is heard medially. ECG has a lot of conduction abnormalities. Absent Q waves in V5, V6 is overemphasized. Presence of Q waves in lead V1 and V2 is again overemphasized. Of the two, if you see, absence of Q wave in V5, V6 would be more sensitive than presence of Q wave in V1 and V2. Therefore, if you are suspecting CCTGA, look at absence of Q waves rather than looking at Q waves in the anterior precordial leads. LAD is also common if there is no PS, but in the presence of PS, they may have right axis deviation. And whenever there is discordance between situs and the abdominal situs and the position of the heart, always think about congenital corrected transposition of great arteries. Now, this particular condition, I wanted to spend a minute or so. PS with intact ventricular septum theoretically is sometimes capped with tetralogy, but theoretically it is no way similar to tetralogy of Fallot. They will have prominent A wave, parasternal heave may be present, pulmonary ejection click if the obstruction at the pulmonary valve. The ejection systolic murmur will have more dynamic variation compared to TOF, and they will have all the signs of right atrial enlargement on ECG as well as X-ray. And as you can see, there are very tall precordial QRS complexes which suggest severe RVH in these conditions. In the same spectrum of patient, if the patient has pulmonary atresia or critical PS with hypoplastic RV, the RV forces would not be seen because here the LV is the dominant ventricle and it will give you the LV forces rather than having any forces on the RV side. And you can have a spectrum of X-ray abnormalities from a nearly normal X-ray to a marked cardiomegaly with prominent right atrial enlargement. So the take-home message is the cyanosis is not same as arterial desaturation. And to my mind, we should be looking at congenital heart diseases with arterial desaturation if we want to not miss out on some of the lesions which may cause milder form of desaturation. Systematic approach permits easy hemodynamic classification of most of the CHD patients, and some findings on examination provide definitive clues to specific diagnosis. Thank you so much.
Yeah. Thank you so much, Dr. Saurabh, for that comprehensive lecture. We will take up the questions towards the end of both the lectures. And it is a great honor to invite my respected teacher, Anja Saxena ma'am. Ma'am is the head of Pediatric Cardiology Department at All India Institute of Medical Sciences. Ma'am is a great teacher and it's a great opportunity for all of us to listen to her teaching once again. I welcome ma'am to give her lecture.
Thank you, Sumod. Am I audible?
Yes, ma'am.
Yes, ma'am.
Okay.
Slides you can share. Yeah.
Yeah, I'm just going to start now. So I think Dr. Saurabh has made my task quite easy because he has discussed a lot of points that I will just skip over. Is my screen visible?
Yes, ma'am. Yes,
Yes, ma'am.
Yeah, it is.
Okay, great. Okay, so what I'm going to do is really restrict myself to cyanotic congenital heart disease during adult life. And I think my approach to the topic will be more from the point of view of the cases that the students get in their DMB exam. So I will not be going into details of, let's say, physiology and hemodynamics, because I think that has been explained very well by Dr. Saurabh, and people would know this by now. But what I'm going to restrict on to cases which are likely to be seen in during adult life, because, for example, transposition, etc., are very, very rare in adult life. So what is the population subtype that we see in adults in terms of cyanotic heart disease? I think the commonest abnormality that we see in older children or adults is the tetralogy or something like a tetralogy, which is also called tetralogy physiology. The other group that we begin to see in adult life, which is never seen in, let's say, infants or children under 2 years, is that of Eisenmenger syndrome. And that usually develops over and above a simple VST or a large PDA at the age of maybe starts at 2-3 years, but then by the time they present to us with cyanosis, it's about the early second decade. We're also getting now more and more post-operative patients, for example, patients who've undergone some surgery in the past, for example, tetralogy. I don't know whether to put them under cyanotic heart disease because they are no more cyanotic now. Then there are patients who have undergone palliative surgery, for example, a BT shunt or a PA band, and they continue to be cyanosed, although the cyanosis severity is much less. And now we're also seeing a lot of patients who've undergone a definitive surgery, for example, Glenn for single ventricle or Fontaine for single ventricle physiologies. So when we look at the underlying cyanotic congenital heart disease, which is unoperated or native congenital heart disease in adults, then I think the common defects with expected survival are tetralogy and Eisenmenger syndrome. Their Epstein anomaly is also seen in adult life because of the bimodal presentation. However, occasionally we do come across very serious defects where you would not have expected adult survival, but rarely you end up seeing some of these. So please don't forget about these conditions, especially condition like unobstructed total anomalous pulmonary venous connection, which sometimes just presents like a simple ASD with little bit of cyanosis. So I think the common defects, as I said, is tetralogy and Eisenmenger. So this is our data of older children more than 12 years of age, including all adults. And as you can see over here, of the cyanotics, we had tetralogy and Eisenmenger in reasonable share of patients. And we've started to see more and more of post-operated patients now in our OPD attendance. However, when I talk to my colleagues who are in private setup, I think more and more adults are now coming up with some kind of surgery being done in the past, almost making 40% of adults with congenital heart disease. So it's the simple rule of history, physical examination, X-ray and ECG. These are the pillars for making the diagnosis of congenital heart disease in anybody. And in adults, when we talk about a history, I think this is what we need to ask. When did the cyanosis start? Has it been the same, or it has improved, or it has increased? I think very importantly, if we want to differentiate tetralogy from Eisenmenger, then we need to see whether we need to ask specifically from the parents if there is any history suggestive of congestive heart failure in infancy in terms of failure to grow, repeated chest infections, etc. How has been the global development? Has there been a history of squatting or cyanotic spells, syncope, seizures? And then, as in any congenital case, we do ask for antenatal history, family history, etc. On examination, again, general appearance, physical development, because in straightforward tetralogy, you don't really expect much of delay in the physical development. Examine pulses, blood pressure, look for features of congestive heart failure. Then for cyanosis, is there any differential cyanosis? How much is the clubbing? Sometimes cyanosis may not appear very severe because the patient is anemic, but the clubbing is significant, suggesting that desaturation is likely to be more. We should take oxygen saturation in at least 3 limbs, that is 2 upper limb and lower limb. Otherwise, you will never be able to diagnose, some conditions where you can have differential cyanosis. And of course, detailed cardiac examination, where you need to look at the situs, where is the heart apex situated? Are there any pulsations elsewhere, like in the second intercostal space? What is apex beat like? Is there any left parasternal heave? And then of course, murmurs and all. So when it comes to precordial examination, one needs to look for thoracic deformities. Many of these patients who undergone some surgery may have a scar, for example, a thoracotomy or a lateral thoracotomy scar or a sternotomy scar. Where is the apex beat? Is there a left parasternal impulse? Remember, dextrocardia may be there in some of these patients. So you have to actually palpate on the right as well as the left side. Look for thrill, systolic and diastolic. And I think second heart sound is very, very important. We've been told again and again, and I think all the students know that second heart sound sort of gives you the diagnosis in very many cases. So it's very, very important to say whether it is single, normally split, wide variable, or fixed split. It is important to hear for S2 in every case that you see during your practice. Sorry. But I think it's very difficult to try and look for it in the exam for the first time. Then you are likely to make a lot of mistakes. So please be very, very careful and look for S2 always while you are examining in your day-to-day practice, rather than just waiting for the exam. Ejection click, inconstant or constant, and then of course murmurs. When it comes to murmur, it is very important that you examine over the front as well as over the back, because some of these patients, especially those who have BAPCAs and all, can you hear me?
Yes, ma'am. Please go ahead, ma'am.
But video?
Ma'am, your screen
that
is
is coming. Madam is changing the computer.
Hello?
Yes, ma'am. Please go ahead, ma'am.
Am I audible?
Yes, ma'am. Yes, ma'am.
Okay, I think something went wrong. So I'm just going to share my screen again. It is not allowing me to share the screen. I don't know why. I think I need to
log off from the previous computer and then it will go.
I've switched it off, but I don't know, it's not going. Is it there still? I think it's gone. Yes, I think now I can share.
Yeah.
Okay, great. So I'll go to the slide that I was on. Okay, so my screen is visible now.
Yes, ma'am.
Yes, ma'am.
All right. So I think what I was trying to say was that we must examine over the front as well as over the back, because some of the patients of pulmonary atresia may have no murmur over the front, but may have a murmur over the back, continuous murmur of collaterals. So when we talk of cyanotic heart disease in adults, how do we differentiate the two most important physiologies that we are going to see in our practice? That is tetralogy and Eisenmenger. And that's your question, I think, very often the students are faced with when they're examining or given a patient in the exam. And I think when we look at the various points in the history, I think some of which have already been highlighted by Dr. Saurabh also. But what is important is to look for any history of CHF in the infancy, which would be a feature of a large VSD or large PDA, which might have gone on to Eisenmenger physiology now. Similarly, history of failure to thrive will be likely a feature of a person who had a large left to right shunt initially, but it's unlikely to be a feature of tetralogy. When it comes to squatting, again, it's more of a feature of tetralogy physiology or tetralogy of Fallot and not so much in Eisenmenger. Syncope and chest pain are likely to be more suggestive of a severe pulmonary arterial hypertension, which is a component of Eisenmenger syndrome. Also, the onset of cyanosis, although it is variable in tetralogy of Fallot, but many of them would be blue at maybe a couple of years of age, whereas Eisenmenger cyanosis is usually later. Most of the time, it comes beyond first decade of life to the parents. So, it is a history. So the parents may not notice cyanosis because it is very mild to begin with. On examination, again, if you want to differentiate, I think 2 points that would be very, very important is are the thrill and the murmur. So basically, because tetralogy of Fallot always has a pulmonary stenosis component, so there will always be a murmur. Of course, if it is very severe stenosis, murmur is going to be short and you may not have a thrill, but in a relatively less cyanosed patient or pink tetralogy, there might be even a systolic thrill. So in Eisenmenger, you never get very loud murmurs. So what you get may be very soft systolic murmurs because of dilated pulmonary artery. And sometimes you may get a pulmonary regurgitation murmur secondary to severe pulmonary arterial hypertension. And this is a hypertensive PR murmur. So murmurs are not very prominent in Eisenmenger, even though those who are mildly cyanosed do not have many murmurs, whereas tetralogy of physiology, if it is mildly cyanosed, will have much prominent murmur and even a thrill along the left sternal border. And of course, X-ray will always tell you the diagnosis, because there is no cardiomegaly in any of them, but there is pulmonary oligemia and pulmonary bay in tetralogy and prominent pulmonary artery segment with at least central pulmonary plethora, although peripheries may be dark in Eisenmenger syndrome. So just a brief overview of tetralogy of Fallot's physiology and how to differentiate it on the bedside. I think when do we say tetralogy of Fallot physiology? There are two key components anatomical. One is there should be severe obstruction to pulmonary blood flow in the form of pulmonary stenosis. And second, that there should be a large ventricular septal defect, which is equalizing RV and LV pressure. And this could actually be a single ventricle also. So these two key components have to be there whenever you are asked to define what is tetralogy of Fallot's physiology. So reduced pulmonary blood flow with normal or less than normal pulmonary artery pressures is the physiological hallmark of tetralogy of Fallot. How do you differ? I mean, obviously there are a number of conditions, and very often you will be asked in the exam, give a list of tetralogy of physiology conditions. So we generally better to divide just to remember, better to divide it into two, with RV dominance, with LV dominance. With RV dominance, you have typical tetralogy, double outlet right ventricle, TGA, CTGA, AVSD with PS. With LV dominance, we have single ventricle and tricuspid atresia predominantly. I have listed pulmonary atresia and Epstein here, which is actually not tetralogy of physiology strictly speaking, but they would also have LV dominance and they will be cyanotic heart diseases. Heterotaxy syndrome are other, which again have a very, not a very good survival to adulthood, but we have to keep that in mind. Clinical assessment of Fallot's normal growth and weight gain. I've already said that when I was comparing with Eisenmenger syndrome. Cyanosis increasing on exertion, JVP not raised, but may show prominent A waves, and no cardiomegaly, no heart failure, no third heart sound, no fourth heart sound, just single second heart sound and a systolic murmur. The severity of murmur depending on the severity of cyanosis, inversely related. But we must remember that in adults, rarely you may have congestive heart failure in tetralogy patients. And, I think that's another question often asked in the exam: enumerate the causes of heart failure in tetralogy of Fallows. So I would give you a couple of cases as we go. This is a 28-year-old male, I know since 2 years of age with shortness of breath, has been class 2, but now recently has become class 3. There is no history of squatting or spell. There is no history of recurrent LRTI or any evidence of heart failure in infancy. So if we go just by history, I think our first diagnosis should be tetralogy or one of its physiological, similar conditions. I don't think we should consider Eisenmenger, although having said that, you cannot be 100% sure because the history of infancy may not be very correctly obtained in a 28-year-old male, especially if you don't have the parents accompanying the patient. So therefore, you need to keep that also in mind. Epstein anomaly is definitely a possibility. And then rare conditions like tetralogy of like TAPVC, etc., which are obviously non-obstructive in somebody who has survived to that age. The examination in this particular patient showed that he is comfortable. His BMI is only 19, pulse was 72, pulse is all palpable, blood pressure 140/82, no respiratory distress, uniform central cyanosis with a saturation of 80% in all the 4 limbs. JVP 6 centimeter of external angle. So it is raised and the A wave is prominent. Apex beat is in the 5th left intercostal space, RV type, no left parasternal heave, single second heart sound, and a loud grade 3/6 ejection systolic murmur at the 3rd and 4th left intercostal space, which is radiating to the back. Lungs are clear, liver is 2 centimeter. So I think we are pretty sure that the diagnosis is likely to be tetralogy of Fallows. We will not consider Eisenmenger syndrome or Epstein's because there is a loud systolic murmur at the 3rd and 4th intercostal space, which is grade 3/6, and therefore we should discard these possibilities. But then there is an odd finding for tetralogy, and which is presence of heart failure, because we saw JVP was 6 centimeter and liver was 2 centimeter below the costal margin. So the question is, what are the causes of heart failure in tetralogy or tetralogy physiology? And I think this is more likely to happen in adults beyond the age of maybe 20 or something. And that could be primarily because of severe hypoxia producing ventricular dysfunction, which could be right and left, but generally right is worse than the left ventricle. Or the VSD may have restricted, producing RV hypertension, which is suprasystemic, and now RV is failing. Or it could be secondary to infective endocarditis, severe aortic regurgitation, because we know the aorta is not abnormal, very dilated, and tends to have, all the adults with tetralogy may have some amount of aortic regurgitation. Systemic hypertension is a very common problem. Whether it is more common in cyanotic is something that we don't have a proven record, but some people believe that yes, it is more common. And sometimes you can have very large collaterals or patent ductus arteriosus producing heart failure. Remember, large MAPCAs is a rare cause of heart failure, because very often when you ask in the exam cause of heart failure, the first answer is large MAPCA. So that's a rare cause of heart failure. Sometimes a very large shunt, especially done in infancy, can produce heart failure over a period of time, and there could be some very unusual reasons like anemia and all. This is a slide that I think has been partly shown by Dr. Saurabh, but I will just try and highlight on physical examination, how can you sort of differentiate tetralogy from others. For example, if you have a prominent A wave, you may be dealing with triology and not tetralogy, but in adulthood, you may have prominent A waves, and tricuspid atresia, especially if the ASD is a little restrictive, will give you prominent A wave. LV type of apex, predominantly in tricuspid atresia and single ventricle. The third cause could be double outlet right ventricle, where the VSD is restrictive and LV has only this as an outlet, and therefore it hypertrophies. Pulsations in the second intercostal space and dull second intercostal space tells you about corrected transposition, or single ventricle where the outflows are inverted. And if you have parasternal heave, which is prominent, which is not a feature of tetralogy, you have to again think about either a triology or with VSD restriction. Dextrocardia, mesocardia with situs solita. That means a mismatch between the visceral and the cardiac situs. Always think of CTGA, VSD, PS. You're going to be correct 80% of the time. AV valve regurgitation, again, suggests AV septal defect or CCTGA. Seesaw murmur of left upper, along the left upper sternal border, topped with absent pulmonary valve, because there is PS and PR. Remember, this PR murmur is low pressure PR and not high pressure PR. Complete heart block, think about CCTG and heterotaxy syndrome. And again, I think as Dr. Saurabh very nicely pointed out, that if you have a mismatch between the murmur and the cyanosis, that means you have a prominent murmur and significant cyanosis. Think about admixture lesion, which have developed pulmonary stenosis. Typical ECG, I think in our case, very clearly showing you right axis deviation, right ventricular hypertrophy, and an early transition, as pointed out by Arrow in V2. suggest that this is tetralogy. X-ray shows no cardiomegaly, pulmonary oligemia. It may not show very typical boot-shaped heart in everybody, but I think absence of cardiomegaly, pulmonary oligemia with not a prominent pulmonary artery segment gives you that this could be compatible with tetralogy. So this patient had most likely tetralogy of Fallot's itself. However, if his ECG or somebody else's ECG, which looks like tetralogy, shows this, that is left axis deviation and only left ventricular hypertrophy, and you can see that the atrial waves are also very, very prominent, because in adults, the right atrium may get very enlarged in patients with tricuspid atresia. So think about tricuspid atresia in such cases. Complete heart block, I've already said that you need to think about CCTGA with PSTPS, because it's almost, if it is present, it's very helpful. If it is not present, of course, it doesn't really work that way. So typical tetralogy of Fallot's X-ray, we know, is a boot-shaped heart, upturned apex, RV apex, pulmonary oligemia, pulmonary bay, and a right-sided aortic arch. But remember, typical X-ray you may not get in all the conditions, in all these conditions. Therefore, if they are there, they are helpful. But if they are not, I think you should not disregard the diagnosis. So this is typical X-ray of tricuspid atresia, where you have an LV apex and an RA cutoff sign because of juxtaposition of the RA appendages. You may have a box-shaped heart or a hump on the left border in a single ventricle, again being caused by the inverted infundibulum. And this is very, very typical that you have a situs solitus, but with dextrocardia or mesocardia and a prominent hump on this side, which is caused by very dilated aorta or L-post aorta. And this is quite typical of CTGA, VSDPS. So it may give you a clue as to which diagnosis you are dealing with if you combine clinical examination, X-ray, and ECG, all three. Now, this is an ECG which is very different from a tetralogy ECG. This also shows right axis deviation, right ventricular hypertrophy, but the prominent part is that you have STT changes and you have no early transition. So it's actually a late transition, and this is quite typical of so-called triology or a severe pulmonary stenosis with intact ventricular septum, or can also be seen with restrictive VSD because RV pressure goes suprasystemic there also. So I'm not going to spend much time on this slide because I think this has been again told to you, but this is again a common question asked in the exam, that why it is tetralogy and why not ASD and PS. And I think the answer will be that left parasternal sheath has to be more prominent in triology. JVP will show more prominent A waves. JVP may actually be raised, especially if RV is dysfunctional. S2, P2 may be heard as a delayed soft component of second heart sound. You may get pulmonary ejection click, which is inconstant, whereas in tetralogy, the click is constant, which is aortic. Because in triology, the obstructions at the valve level. And of course, you have murmur, which is proportional to the severity of cyanosis and not inversely proportional like you have here. And ECG I already showed you will show prominent RVS, late transition, and STT changes of strain. X-ray may show you cardiomegaly, but pulmonary artery segment is going to be dilated because of the valvular component of the pulmonary stenosis in ASD and PS. The second common disease that we see in adults is Eisenmenger syndrome, which I think is very well defined for a long time, where we expect the shunt to be reversed or bidirectional. So it can be, may not be always right to left, it could be bidirectional also. So what is the difference between tetralogy and Eisenmenger physiology? I think in tetralogy, there's an anatomic obstruction leading to reduced pulmonary blood flow. The pulmonary artery pressures are normal or less than normal. On the other hand, in Eisenmenger syndrome, also the pulmonary blood flow is reduced, but that is reduced because of the high pulmonary vascular resistance offered by the capillaries of the pulmonary vasculature, and therefore the pulmonary artery pressures are actually severely elevated. They are systemic in a VSD or a PDA, so they are systemic. So Eisenmenger syndrome also has low pulmonary blood flow, and that is an important thing to remember. It doesn't fall into the category of high flow. The pressures are high, but the flow is reduced. We all know it is most often secondary to large ventricular septal defect or a large PTA. AP window is a relatively rare disease, but it can produce very early Eisenmenger syndrome. ASD, I think a lot of people believe does not produce Eisenmenger physiology. It is a coincidental PAH and ASD. So we don't know whether ASD goes into Eisenmenger, but yes, most of the books will say that in the 4th or 5th decade, they can go into Eisenmenger. And then we have another huge group of cyanotic heart disease, which may go into Eisenmenger if they survive. They have a very poor survival. So exceptionally, some of them survive and they may go into Eisenmenger physiology as well. X-ray of Eisenmenger, I already showed you one prominent pulmonary artery segment, absence of cardiomegaly, central plethora, peripheral oligemia. The question asked is often, how do you differentiate whether it is VSD Eisenmenger, PD Eisenmenger, or ASD Eisenmenger? And I think that's a common scenario in the exam. So I think this table just highlights some of the points. The age of onset is earlier in VSD-PDA. It is much later, as I told you, for ASD. And differential cyanosis. Differential cyanosis is very, very helpful if present. But remember, in 50% of PDAs, it is not present. So if it is present, it's very helpful. And you must make sure that you put the right hand with one of the foot to one of the feet to see whether there's differential signs or not. Unless you put it side by side, you may not appreciate the difference very much. Or of course, you can always do pulse oximetry to see the difference. In ASD, you will have cardiomegaly, but I think the best differentiation is by the second heart sound, and this is what has been there for a very long time, in Paul Wood series also, that if you have a single second sound, you call it VSD. If you have a narrow split or a normal split, call it PDA. If it is wide and fixed, it will be ASD. Parasternal heave, unlikely in VSD PDA because the RV pressure never goes beyond LV pressures. And similarly, tricuspid regurgitation murmur may be there in ASD because right ventricular dilatation is much more in ASD compared to the other two conditions. Pulmonary regurgitation murmur is secondary to PH and can occur in any of the conditions, but it is typically described in PDA. So if you have a PR murmur in an Eisenmenger, please make a diagnosis of patent ductus arteriosus. This is a 25-year-old lady who's recently married, has presented with mild dyspnea and fatigue. She's very minimally cyanosed. In fact, parents or the family did not even pick up cyanosis. There's no evidence of heart failure. First heart sound is normal. Second heart sound is single. There is no murmur. What is the diagnosis? I think we would put it as Eisenmenger. Because there is no murmur, one can think about pulmonary atresia with VSD. But remember, pulmonary atresia with VSD survival is not so good. And secondly, they are likely to be more blue unless they have really large MAPCAs. But if there are large MAPCAs, they will produce murmur also. So most likely the diagnosis is Eisenmenger syndrome. This is the X-ray. You can see that typically Eisenmenger syndrome X-ray. The question is, what is the level of the shunt? Whether it was your ASD, BSD, PD, or AP window or any other. And as I said that we go often by the second heart sound, and you can see the second heart sound being single goes more in favor of a ventricular septal defect. However, by X-ray also you may get a clue. For example, in ASD Eisenmenger, you will have cardiomegaly and you will have right atrial enlargement as shown over here. In a PDA, you will have very prominent pulmonary artery segment, but in addition, the aorta will also be prominent because the PDA is over here. So the aorta also tends to be prominent. And in a VSD, you may get some amount of left ventricle and left atrial dilatation, but there's no right atrial dilatation, no aortic dilatation. So you can differentiate to some extent by X-ray chest, but of course, it doesn't have very good sensitivity. ECG typically will show whatever the lesion may be, right axis deviation, right ventricular hypertrophy. However, if there are prominent LV forces, especially if the patient is clinically not blue, I think you must not make them Eisenmenger syndrome. You must think about whether this patient may still be operable, and therefore you may have to go on for further tests like cardiac aspiration, etc. But only if there are good LV forces, because that is what you expect in a VSD PDA. If there is a left to right shunt still happening, LV should stay volume loaded. So the same lady, you can see the contrast echo, and I think it's quite obvious that there is a little bit of contrast going from the right ventricle to the left ventricle across a VSD. The question is, because she's recently married, nobody knew that she has this disease. Family is very keen to have a baby. She's only class 2, very little symptomatic. The question is, should we allow her to get pregnant? Unfortunately, I can't ask you that question but most of the time, I think we all know that Eisenmenger syndromes are very, very high risk for pregnancy, and therefore pregnancy is actually contraindicated according to the latest guidelines that have been published in European Society of Cardiology of pregnancy with heart disease. And this is categorized as modified WHO risk class 4, and is actually a contraindication. And we need to tell them right there and then that no, it has a very high maternal mortality. And I think the family generally would be very keen, and therefore we have to counsel them very well. So much so that if the pregnancy occurs, even termination has to be discussed unless they come beyond the stage of termination. This is an 18-year-old man presenting with palpitations, minimal cyanosis, no heart failure, wide split second heart sound, and a short systolic murmur. And I think when we say wide split second heart sound in a cyanotic adult, these are the list of conditions that come to our mind. Of these, abstinence anomaly is quite likely because patient is again very little symptomatic, just with palpitations. Of course, remember, very large AST can also give you mild cyanosis even without undergoing Eisenmenger reaction. So very large ASD because of mixing, like a common atrium, can give you mild cyanosis. TAPVC unobstructed can also give you widespread second heart sound. And then there are rare conditions like ASD with IVC blood streaming into LA or left SVC going into coronary sinus. And rarely anomalous systemic venous drainage can also give you cyanosis when there is a ASD also. So this is cardiomegaly, quite a big heart, but patient is not in failure. And the ECG is quite typical of Epstein's anomaly. So X-ray and ECG almost gives you the diagnosis right there and then. But sometimes you may have a very typical X-ray, like a figure of 8, and that's not uncommon in adults with supracardiac PAPVC that you get typical snowman's heart, and then the diagnosis is quite obvious. So cardiomegaly, snowman's heart, plethora. I think whenever you have cardiomegaly on X-ray chest but no CHF, you have to think of these conditions, which I've just enumerated. I'm just going to show you one of maybe one or two more cases. This is an 18-year-old girl with deep cyanosis having dyspnea and fatigue since early childhood. 18-year-old, but deeply cyanosed. You can see saturation of 60%, still not in heart failure, has an RV impulse, which is grade 2, single second heart sound, no murmur, right axis division, right ventricular hypertrophy. I think we are going to diagnose this girl as VSD pulmonary atresia because she's very blue and she has no murmur, or maybe a very severe tetralogy of Fallows. Could be Eisenmenger, but unlikely unless we say Eisenmenger to one of the complex heart diseases. But I think the clue is that RV impulse is quite a lot. So suggesting that her RV pressure is going to be more than LV pressure, and therefore a large VSD is very unlikely in this situation. This is the X-ray, which clearly tells you that there is increased vascularity, although cardiomegaly is not there, plethora is there, and pulmonary artery segment is prominent. To our surprise, her X-ray, echocardiography showed a normal 4-chamber view, a large ASD. But what is important is that the vessel which is arising from the left ventricle is actually dividing into 2 branches, and the vessel which is arising from right ventricle is not dividing into branches. So this is aorta. Aorta is from RV, pulmonary artery is from LV, and there is a large ASD, and that is what has kept her alive, although at a very deep cyanotic level. But it's not uncommon to see these patients coming from rural background where they don't even seek any medical attention for a long time. But now she became very symptomatic, and that's how she came. So this is, one of the exceptional survivors of complex CSD, which I'm sure all of us are going to see and all of us see in our practice. Although I think if you think about Western literature, they wouldn't be seeing such patients, but we do sometimes see complex heart disease, which have a very high mortality in infancy, still coming to us during adult life. So please don't close your eyes to these rare conditions also. Sometimes these things can also come to our attention. 22-year-old boy who came to us with hemoptysis. This is actually, I think about a year ago. Recurrent hemoptysis for the last 2 years. We've done APC coiling several times. He was cyanosed since 6 months of age, VT shunt at 18 months, Glenn at 5 years. Gradually increasing cyanosis. We catheterized her when we found that the pulmonary arteries are quite small and not suitable for spontaneous surgery. Saturations were quite low. X-ray shows quite a significant patch on the left side. ECG is suggestive of complex underlying heart disease. And the issue is why he's having increasing cyanosis and why he's hemoptizing. So increasing cyanosis, I think, is a natural phenomena following Glenn. As the patients get into their adult life, the IVC contribution to the systemic venous flow increases, and therefore their cyanosis worsens. So Glenn may be quite comfortable till 5, 6, 7, 8 years of age, but during adulthood, even a perfectly functioning Glenn will become more and more blue. And then on top of that, they can also develop pulmonary AV fistulae. And these patients may have hemoptysis from collaterals, from pulmonary fistulae, or even sometimes associated with pulmonary tuberculosis. I think we've all seen these cases quite often in our practice. But this patient had really large pulmonary fistulae which needed to be closed with a vascular plug. I think finally, cyanosis with absolutely normal cardiac examination. I think we all know the causes: total anomalous systemic venous drainage, unroofed coronary sinus, left SVC draining into LA, and pulmonary AV malformation. So examination is normal. ECG may also be normal, but the child is blue. And I think the diagnosis is quite easy to do with a contrast echo. So pulmonary AV malformations are congenital in most cases, can develop post-Glenn. I think rare cause of pulmonary malformation is abundance malformation, and these are the rare causes that I have listed. And echo with saline contrast injection, I think we all know, is quite diagnostic, even if clinical X-ray, ECG, everything is normal. So to summarize, I will just give you 4 scenarios. No left parasternal heave, single second heart sound, good ejection systolic murmur at the left sternal border, middle and lower. Think about tetralogy. Quiet precordium, multiple sounds, very soft murmurs. Think about Epstein's. Left parasternal heave with a wide fixed S2 with P2 audible, ejection systolic murmur and flow MDM at the lower external border. Think about like findings of ASD, basically. Think about TAPVC. And finally, no left parasternal heave, single second sound, but very soft murmurs, maybe an early diastolic murmur. You have to think about Eisenmenger syndrome. Thank you for your attention.
Thank you so much, ma'am, for the elaborate and lucid evaluation of sinus in adult. There are some questions which, if you are comfortable, ma'am, we can take some questions here.
Sure.
Some of the questions which find their lot of questions on second heart sound. So one question is, what are the cause of palpable S2 and how to differentiate that, whether it is A2 or P2?
Especially in a situation where the child is very or child or adult is very cyanotic, and which could be VST or pulmonary atresia, or it could be VST Eisenmenger. Now based on the second sound itself, can we say it is A2 or P2?
Okay, I take this one.
Yes, ma'am, please.
Okay, so I think to say whether it is A2 or it is P2 or a combination of A2 and P2 is very, very tough. You have to go by circumstantial evidence, because there is no difference between A2 and P2 in terms of their auscultatory capabilities or auscultatory characters. Sorry, not capability, auscultatory characters. So I think what we have to do is to look at the entire picture. If it is a single second heart sound, it can be pulmonary atresia or with VSD, or it can be Eisenmenger's VSD, sure. But pulmonary atresia patients are likely to be much more blue than patients of Eisenmenger syndrome, because Eisenmenger syndrome with VSD usually starts to become more and more blue in late in their 40s and 50s. Generally, their saturation will be more like 85% and above. Whereas pulmonary atresias with VSD, first of all, is likely to present much earlier in life, and they will have much more cyanosis. But if they are less cyanosed, then perhaps they will have murmurs of collaterals, murmur of MAPCAs over the back or over the front. So we have to really say that whether it is A2 or it is A2 plus P2 or it is P2 alone, only based on circumstantial evidence and the rest of the findings.
I'll just add that it should be based on the company it keeps. The sound itself is not discriminatory. It is as ma'am just said, it will depend upon the company of others sign and symptoms which will be there in this patient, and the examination of other cardiological findings.
And one question is, what is the basic mechanism of pink TOF?
We say that all tetralogies are severe PS. Then why somebody is not cyanosed and why somebody is cyanosed?
This term is often not accepted by many of the examiners also, so they are personally messaging. So how do we define this and how do we clarify?
So shall I take this one?
Yeah, please.
So, tetralogy always has severe RVOT obstruction, but because of the favorable streaming, the reduction in pulmonary blood flow is not always to the extent when it reduces it lesser than the pulmonary blood flow. So they may still continue to have good amount of systemic venous blood reaching to the lungs for good oxygenation. And once a good decent amount of blood reaches lungs for oxygenation, they will continue to have either no or minimal desaturation. Since pink is a observation finding, TOF is a anatomical finding. Now we are combining the two. So pink just says that the patient has minimal amount of desaturation and there is no visible cyanosis. Tetralogy, the diagnosis comes from echo and the morphological diagnosis. So these two are not, I think they are very much compatible with each other. Ma'am?
Yeah, I think you're right. I just want to add that in tetralogy, the degree of cyanosis depends on the degree of anatomical obstruction. And we should say that it is always severe. It is severe, more severe, and most severe. But if you look at the PA, if you see the gradient across the right ventricular outflow tract, PA pressures are normal or low. So therefore, and RV pressure is systemic. So therefore, the gradients are always severe or significant. It has to be 70, 80 gradient to call it tetralogy, because PA pressure should not be elevated in a tetralogy. Those kind of condition we should call VSD, PS, PAH. But in tetralogy, PS is always severe, because I've heard this from some of the students saying that pink tetralogy has mild PS or moderate PS. That's incorrect. PS is always severe because PA pressure systemic is 20 or 25, but RV pressure is 100, so you have a gradient of 80 anyway. But it depends on the severity of anatomic obstruction that will determine how much flow is happening into the lungs. And if the flow is not too bad, then one can get a tetralogy, which is minimally cyanosed, or some people like to call it pink tetralogy. But tetralogy is a very specific condition where you have those 4 components, whereas and most of it comes from anatomical diagnosis, which is made on echo. But I think clinically, we should still call it tetralogy. If you have a blue patient who looks like tetralogy clinically, we should call it tetralogy because it's the commonest, very commonest cyanotic heart disease. But let's not think that pink tetralogy is a less mild tetralogy.
Yeah, and in tetralogy, the saturation tells us the severity. As also ma'am has emphasized, the gradient will always be higher. So mild cyanosis is indicative of milder form of tetralogy because it indicates milder form of RVOT obstruction. More is the desaturation, more severe is the RVOT obstruction.
Yeah, one question is, what is the mechanism of cyanosis in Epstein's anomaly?
Cyanosis in Epstein's anomaly is often because of the right to left at the atrial level. So in neonatal period, when their pulmonary vascular resistance is very high, the tricuspid regurgitation is hypertensive tricuspid regurgitation because it's an abnormal tricuspid valve, and that produces a lot of right to left shunt. So these patients tend to be more blue. But as the PVR gets better, the TR velocity goes down, the TR going into the left atrium also becomes less, and the patients become less and less blue. In fact, many Epsteins may not be blue at all, but the mechanism of cyanosis is right to left shunt across the ASD level, primarily because of severe TR. That is part of the Epstein's anomaly.
Yeah,
even later on, ASD is present in almost 85 to 90% of patients with Epstein. So, and the RV, depending upon the RV cavity size, once the child is grown up, it may not accommodate and it may continue to have some right to left shunt. That is why there is bimodal. The first presentation of cyanosis is because of high PVRI, as was told by ma'am. And later on, they present with low velocity right to left flow across ASD.
Saurabh, 3 of the different residents are asking very simple completion sake questions, which is that why there is early transition in TOF, number 1. And the second thing they are asking is that how should we exactly present the diagnosis? 3 or 4 people have separately messaged that what should be the complete diagnostic presentation of the diagnosis of in a case of cyanotic congenital heart disease. And the third one is that how do you say that infections are recurrent respiratory infections?
I think first 2 ma'am will definitely take much better than me. She has been
please,
all along. So ma'am will tell.
What is the first question?
The first one is about early transition in TOF.
Okay, so I think a lot of people believe that because of a large VSD that is present, you get the forces of the left ventricle quickly because of large VSD. Although I think Dr. Tandon, I used to ask this question, he always said, we don't know. I don't know. That's what the answer used to be. But when I saw people discussing it in various fora, I thought a lot of people said that because of a large VSD sitting right underneath, you get it very quick transition from the right ventricle to left ventricle. Right ventricle is not enlarged in this condition, whereas when you think about pulmonary stenosis, the intact ventricular septum, RV occupies much bigger space than the tetralogy, because we know in tetralogy, RV is not enlarged. The second question is about complete diagnosis. I think in the exam, most of the examiners are quite finicky about having a complete diagnosis. So please start with congenital cyanotic heart disease. And then you can say tetralogy of Fallot's physiology. For example, you're talking about a tetralogy physiology. And then you can say that these are the possibilities. For example, tetralogy of physiology is number 1. then you can think about double outlet right ventricle. If you have an LV apex, obviously you have to put tricuspid atresia and single ventricle, and not tetralogy. And then you say about the rhythm, about the heart failure part, anemia, infection, the usual 5-6 things that you have to say, and NYHA class. So I think you have to complete that. Only thing we don't talk about in tetralogy is PVH, because most of the rheumatic heart that you get in the exam, you have to talk about PVH, PH and all. In tetralogy, it is kind of taken that there is no PVH and there is no PH. When it comes to Eisenmenger, then your diagnosis should be congenital cyanotic heart disease, Eisenmenger syndrome. Again, you need to specify secondary to a large VSD or large PTA or large ASD, whatever you think from your physical findings. And again, severe PHs need not be said because this is very much in print in the diagnosis. And then, of course, rhythm, NYHA class, any other associations, etc. I that's what they mean.
Ma'am, if I can add here,
yeah.
Like if sometime if we find a case of TAPVC or other conditions where the pulmonary blood flow may be increased, then we should say cyanotic congenital heart disease, increase pulmonary blood flow, and then go to the lesion diagnosis. Will that be okay, ma'am?
Yes, absolutely. I mean, it depends on which diagnosis are you considering. If you are saying tetralogy,
Yes.
you can say reduced pulmonary blood flow. For
So,
Eisenmenger, generally
yes,
we don't talk about pulmonary blood flow. But yes, if TAPVC is there, then we talk about increased pulmonary blood flow. Sure.
So it would be like cyanotic congenital heart disease. Then we comment upon the pulmonary blood flow. Then we go to the physiology, which we are talking about, tau physiology, say admixture physiology or Eisenmenger, and then we move on. In Eisenmenger, we need not say about pulmonary blood flow.
And recurrent respiratory infection. Recurrent respiratory infection.
I think any life-threatening LRTI or more than 3. I mean, I think one of the WHO manual writes it more than 3 LRTI in a year. But practically what we follow, what I follow is, ma'am can confirm, that anybody who has had any life-threatening infection requiring admission, and if more so if it has required ventilation, then it is good enough to be indicating serious congenital heart disease underlying. Otherwise, if the child is having more than 3 episodes in a year, it should be counted as recurrent. Ma'am?
Yeah, I think the number of 3 episodes or more, which are either requiring antibiotics or hospitalization, is something that WHO says. As far as one serious life-threatening infection requiring hospitalization infection, I think that is a criteria that we use for sending these patients for surgery.
Yes,
like if you have a patient with moderate VSD where you can otherwise wait, but if somebody has had a very serious LRTI and has been admitted and ventilated, then this patient should be operated. But if you are asked in the history, have you had recurrent LRTIs in the past, and the examiner asks you, what do you mean by that? Then I think it's better to say 3 or more LRTIs. Remember, it is lower respiratory tract infection requiring antibiotics.
And not URI, as a lot of kids may have. That should not be counted.
Another common is the clockwise and counterclockwise looping, why it occurs in DRV. So how do you explain to the PGs what is clockwise rotation and counterclockwise rotation?
So I think this is an ECG question, I suppose. Yes. So you have Q in 1 in ABL, or you have Q in 2-3 ABF. So most of the time, 1 in ABL will go with left axis deviation or a northwest axis. So if you have a double outlet right ventricle patient where the axis is falling into the northwest zone, then you need to decide whether it is an extreme right or it is a left axis deviation. So then you need to look at 1 in ABL. If the Q is in 1 in ABL, you're going to take it as extreme left axis deviation. Whereas if it is in 2-3 ABF, you're going to say it is in right axis, it's a right axis deviation. So, I mean, it doesn't have a great value as of today, because I think it is just looking at 2 vectors. So it is not necessarily telling you the truth, but that is what the bedside, the best you can do at the bedside.
Another difficult question is
why there is
display.
Go ahead,
Yeah. why there is dyspnea in pulmonary stenosis. PH could be due to the receptor theory. So why there is dyspnea, and no, should you prescribe diuretics for this dyspnea that is occurring in pulmonary stenosis or PH?
Why there is dyspnea in pulmonary stenosis?
Why there is
Okay,
dyspnea?
so yeah, so I think if we are talking of a cyanotic condition and not just pulmonary stenosis, which is pink, with a normal heart function, sorry.
In cyanotic heart disease, we know that this is due to decreased blood forward flow. But apart from decreased forward flow, is there any other mechanism that we can say isolated PS?
I think it's more because of hypoxia and the respiratory muscles get tired very fast, and that produces some amount of dyspnea in a pulmonary stenotic situation. In pulmonary artery hypertension, it's a different mechanism. As you said, it's more to do with receptors, J receptors.
No, in the absence
But
of
if,
cyanosis,
but if the pulmonary stenosis does not have cyanosis, and it has to be severe, then it is limitation on exercise to increase the pulmonary blood flow. That may be the mechanism why they feel dyspnea. So if a patient is having pulmonary stenosis, it is very, very unlikely to cause dyspnea of more than class 3 if it is not severe and not having associated RV problem.
Yeah, if there is RV dysfunction, of course, it can be explained. But
yes, otherwise,
but otherwise it will be quite unusual. And as far as diuretics are concerned, I would not give diuretics to a pulmonary stenosis patient. Unless, of course, you have no cyanosis, patient is in gross heart failure, and you are not taking the patient to lab immediately for a balloon dilatation in a pulmonary stenosis intact ventricular septum patient. But if it is a tetralogy kind of a patient, diuretics are absolutely contraindicated in these patients.
In PS, I would just add what just ma'am said. Even diuretic may be counterproductive, because in pulmonary stenosis, if the patient is really sick, then they need that preload to circumvent that obstruction. And if you reduce the preload, you are rather doing harm than good. So it should be avoided. The treatment should be relief of the obstruction.
Totally agree. There's one question. Is there anything like taxology of fellow?
Taxology?
Yeah.
Taxology.
No, I haven't heard, ma'am.
You mean after pentology?
Yes, ma'am.
I'm sure the one which has a PD also. I'm sure it must be the one which has a PD also, but this is a guess, wild guess.
Yes. Ma'am, they are asking.
Man, what about the systolic thrill in second and third intercostal space in a patient who is cyanotic?
So if you have a systolic thrill, that only tells you the turbulence across the pulmonary outflow tract. So in a patient who has tetralogy or a tetralogy-like physiology, the murmur is actually coming from the pulmonary outflow tract. And if too much flow is going still, then you will have a louder murmur, and then sort of translates into thrill. So basically, in a tetralogy patient, in a simple tetralogy patient, thrill would mean good pulmonary blood flow. And therefore, these are the patients who are likely to be less cyanosed. And that's why we say there is an inverse relationship between the severity of cyanosis and the loudness of the murmur, which is true for thrill also. But if you are talking of conditions like transposition with BSD-PS, where there is an additional reason for cyanosis, other than reduced pulmonary blood flow, that means there is a mixture also. Those are the patients, they may have severe cyanosis and still have a thrill. And that's what Saurav was trying to point out, that the relationship between the cyanosis and the murmur is lost in patients who have admixture lesion with pulmonary stenosis.
So just to elaborate further on that, what just ma'am said. So like those so-called pink tetralogy, many a times will have thrill. And it is usually because the pulmonary blood flow is high. It is also associated with a very soft delayed P2 because the flow is more. So it will allow that thing. And it also means that it may also mean that the pulmonary valve thickness is not so much. It is not so dysplastic. It is moving little well. So combining all this, if the patient has thrill and a mobile pulmonary valve, they'll have a combination of thrill plus a soft P2, which will also be hard.
Will the Hoffman variant have a thrill? Dr. Saurav?
Yeah, if the pulmonary, it will all depend upon the RV outflow resistance. So if the patient is so Hoffman variant has nothing to do with the, it can still happen in milder form of cyanosis. So it may very well happen in that case also.
But if the VSD is really become restrictive, then the VSD itself can also produce a murmur.
Yes, ma'am. Then it will behave more like restrictive VSD,
Right. Right.
like PS with intact ventricular septum, and VSD giving the murmur.
Yeah.
Then the murmur will change to pensystolic murmur,
Yes,
maybe.
yes, that's what I mean. Like a DORV with restrictive VSD or a tetralogy with restrictive VSD can have a murmur because of the VSD, in addition to the murmur because of RVOT. But in the exam, it is better not to talk about two murmurs in the same area because nobody can really differentiate. I've seen students doing that in the second space they can hear an ejection systolic murmur, in the third space they can hear a pansystolic murmur. I think that's a very, very theoretical thing, and therefore better not to commit that in the exam.
And one last question, then. Mechanism of use of beta blockers in tetralogy of Fallot. Not in spell, but routinely patients have been prescribed with propranolol. So what is the mechanism? How do they benefit?
So beta blockers produce slowing of the heart rate. That's first mechanism, because tachycardia is always detrimental for tetralogy of Fallot's patients, because the more tachycardia, the more or the less chance for the pulmonary outflow to for the pulmonary flow to happen. So they produce bradycardia. That's number one. Number two, they probably relax the muscle. Although once I say that, a lot of people say that we are also using in pulmonary atresia. And in pulmonary atresia, there is no relaxation of the muscle that is going to happen. So I think that's another mechanism that works at least for tetralogy, if not for pulmonary atresia.
Ma'am, some of
Saurabh, you want to add anything to that?
And as such, we know that once we use non-selective beta blockers, it works on the cardiac energetics. So it reduces the oxygen requirement of the cardiac muscles. So that way also it should be helping. I think these are the mechanisms they write in the books.
Some people ask that while describing, should we be using NYHA classification in adult congenital heart disease?
In adults, yes, you should, you can. Although there are a couple of other classifications for cyanotic heart disease, but I think everybody is very, very familiar with NYHA class, the examiners as well as the students. And for the as far as the specific classification for cyanotic heart are too many, and I don't think any of them is as well standardized as NYHA. But when it comes to children, especially under 6 years of age, I think we should avoid using NYHA and instead use the modified Ross class.
Another thing, ma'am, is that I think almost 5-7 people have asked that what do you mean by obligatory shunt? If
I will leave it to for Saurabh because he would explain it very well.
Ma'am, okay. So obligatory shunt means that irrespective of the flows, I mean the gradients, the flow will happen. Like for example, in TAPVC, if the flow does not happen across ASD, the circulation won't work. So it has to flow. Similarly, in DORV, if there is aorta, if the left ventricular outflow has only one outflow, which is the VSD, if there is obstruction at that level, if the VSD is restrictive, then it has to flow. So these are the ones which are like obligatory flows.
So basically, obligatory flows means that flow will occur irrespective of the pressures.
Irrespective.
And the other example is RSOV.
Other RSOV, yes.
Yeah. What is the best mechanism to explain cyanotic spell, and why do they disappear as they grow old?
So cyanotic spells basically has multiple mechanisms depending upon the underlying etiology. One of the mechanisms what can explain the maximum peak at 2 to 6 months is that this also is the time when the child is having steadily increasing requirement. there is further increase in the RBOT obstruction because of progressive flow across that area. Overall fibrosis is taking place. So there is increase in the RBOT obstruction. The demands of the baby are increasing, and it also coincides with the time at which there is iron deficiency anemia. So putting all these together, there is peak between 2 to 6 months, and thereafter child also develops some of the compensatory mechanisms. The nutrition part also improves, and the increase in the requirements, which are rapidly changing in the early infancy, are not changing so much later on. After 2 years, when the child is moving around, the symptoms are indirectly telling the child to restrict the activities, and they develop those mechanisms which stop having cyanotic
Actually,
spells. Ma'am?
They actually start squatting. By to abort a spell, they start squatting. And when they are even older, then they don't squat because they find that to be odd. So they usually cross their legs while standing. So they sort of learn a mechanism to not the spell to come to the full picture. And that's how it goes away.
Ma'am, what about the diagnosis and management of anemia in these patients of cyanotic congenital heart disease? How do we diagnose simply, and what are the simple ways to manage anemia?
I think simple way to diagnose is to look at the hemoglobin, although a lot of people would do iron and other things. And I think depending on the saturation, your hemoglobin levels have to be more. So if somebody is very severely desaturated, I think he should maintain a hemoglobin more than 14, 15 or even higher. You know, we've been transfusing even at 14 sometimes if somebody is coming with a spell. That's more of a problem in younger children. In adults, usually anemia is not a major issue. But if you do their iron levels, yes, sometimes they will have depletion of iron levels, and that will be a better way to tailor their treatment. But iron is something we quite commonly give to children. We don't give it so often for adults because they tend to become polycythemic sometimes, and that would give them symptoms of polycythemia.
One last, brain abscesses and CVA, the best mechanism to explain the brain abscess and CVA in cyanotic heart disease.
Brain abscess is more common beyond 2 to 3 years of life, whereas anemic infarcts are more common in younger children. So generally, if somebody comes with a stroke at 1 year or 1.5 years of age, I think you're going to find that child to be anemic, significantly anemic for that degree of saturation. Hemoglobin may come up as 10, but if the saturation is 60 or 65%, then that is really very low. And these are the patients who tend to develop hypercoagulability or, you know, abnormality of RBC fragility, not fragility, RBC adherence. So the RBCs tend to flock together and produce thrombosis and produce CVA. In older children, it is mostly some infection on the venous side, which travels from right to left and therefore produces infection of the brain. And they may or may not give you history of fever. Sometimes they do, but I think you have to have a very high suspicious or index of suspicion in those where you would think long low-grade fever, or those who are little, you know, showing a little bit of neurological features, vomiting, headache, etc. You have to keep a very high index of suspicion and, you know, get their CT done. But generally, the age group is quite classical. Younger children will hardly ever have brain abscess, and older children will hardly ever have anemic infarcts.
Thank you so much, ma'am. And I think these questions will be never ending. We are getting thousands and thousands of questions, and it's been absolute pleasure and great learning for me and for almost everyone who are there with us on this journey. And it's a great beginning. Fantastic lectures, Dr. Saurabh and Madam. It's absolute pleasure to have you, and Professor Sumodh and Dr. Girish. It's again, thank you so much for moderating the session so nicely. And we had more than 660 people, residents, who joined today with us, and we are really delighted. And I think if there are more questions, you can definitely write to us. This will at least stimulate all of us to read more on this topic, go in further depth. These presentations will be made available to you on YouTube. You can listen to these lectures again. and again rejuvenate, because it's very difficult for you to catch. And if you want to listen and have some more clarifications of particular topics that you want our experts to address, then you can definitely write to us on PG Track CSI Delhi Branch at db@gmail.com. Thank you so much, all of you, for joining us once again. And we'll be meeting up next week again with another series of lecture, probably on rheumatic heart disease. And catch you soon. Thank you so much. Thank you.
Thank you, Mohit, for taking this initiative. I think you're doing a wonderful job for the students, and I'm sure more and more will join as the word spread. I'm really surprised that so many of them have joined. I think this is really, really fantastic. Thanks to you, and we can imagine, we can really work very well even in the lockdown. It just goes on to say that where there is a will, there is a way. Thank you
So much. Thank you,
That's
Saurabh.
right.
Thank you, Dr. Mohit. Thank you, Dr. Girish, and everybody else. Thank you so much.
Thank you so more than Girish, and we'll catch up later. Thank you.
Thank you.